Hello, good evening, everyone. Welcome to this yet another Gujarat Pediatrician WhatsApp group webinar, which we do every month on different topics. Dr. Ramesh Vajania, who is the creator of this WhatsApp group, is also here, and we are all very happy to welcome you all. Thank you for taking out your time and joining for today's discussion. Today, we have a very heavy faculty and a very important topic of seizures in children. So I'm sure all of you will enjoy it. It's a very day-to-day absolutely ground level type of discussion that we will do. This is the 12th in a row, except the one which we did not have during the election time. Otherwise, this is the 12th in a row webinar this year after we restarted. Of course, this Gujarat Vidyartition webinars are going on for more than 10 years now. And during COVID time, of course, it really helped a lot of people to understand the nuances of what happens during COVID time. So back to today's topic, which is seizures in children, and we have Dr. Rajesh Udani, Dr. Lokesh Lingappa, and Dr. Nitish Vora as our esteemed faculty. I will hand over mic to Dr. Ramesh Vajana to introduce the faculty.
Yes. Good evening, all respected seniors and dear friends. Welcome to yet another academic session from Gujarat Pediatrician WhatsApp webinar series. As Nitin Bhai said, we started in 2016. To begin with, it was in a text form. So Nitin Bhai coined it as a seminar. And since then, we have been organizing. And the format is such that the day-to-day practice, a common colleague would find it helpful. So today we have got three very, very eminent faculties. And first is Dr. Nitish Vora. He is yet our own from Ahmedabad. And Nitish Bhai is a very prominent name as far as academic circle is concerned. He has done his MBBS and MD from Ahmedabad, and then he went to UK for his MRCPH. And he's British board trained neurologist. Regularly, he has been organizing conferences related to neurology and specifically epilepsy. He has been recipient of Gujarat No Gaurav Award and Best Academic Poster at ICNC 2018. He has a special interest in epilepsy, brain injury, and autism. So welcome, Dr. Nitish Vora, sir.
Thank you, Ramesh sir and Nitin sir and everyone. Thank you.
And another speaker, very again eminent academician is Dr. Lokesh Lingappa. He is a little busy, but fully he will join after a few minutes. He is a clinical lead division of pediatric neurosciences, consultant child and adolescent neurologist at Rainbow Children Hospital, Hyderabad. And his areas of interest are critical care neurology, stroke, one of 3 centers for DNP, pediatric, and neurology. So welcome, Dr. Lokesh, sir.
One more thing about Dr. Lokesh is that his wife is a very eminent pediatric hemato-oncologist, again from Rainbow, Hyderabad, very good friend of mine. And I don't know whether she's my best friend or is Lokesh my best friend. Of course, I will say she's my best friend because we are in the same field of pediatric hemo. And last but not the least is our own Dr. Brajesh Udani. He's like a doyen of pediatric neurology, an extremely illustrious child of an even more illustrious father, Dr. P.M. Udani. He works at PD Hinduja Hospital, also at Khar Hinduja Hospital. He was a consultant in JJ Hospital, still goes for teaching to Vijayawadi Hospital children, and has started the fellowship program in pediatric neurology years back. Many of his students are now in Gujarat and every nook and corner of the country. And he is like, I would say, in the top few pediatric neurologists, not only in India, but in the world. And his knowledge is amazing. His way of thinking is absolutely clinical. And I love him as Mota Bhai. And I always say that अगर मुझे और एक chance मिले अगले जन्म में तो मैं मोटा भाई के जैसे pediatric neurology बनूंगा. So with that, we start with today's webinar, and today we are going to discuss seizure in children. So I will start with first Nitish. Nitish, a lot of terms are used. You know, people use seizure, convulsion, fit, paroxysm. So I mean, when do you use which term, or what is the actual meaning of these terms? And which is the correct term?
So I think all these terms are used interconnectedly by different people, either laymen or doctors or specialists. But what we mean literally by those things, seizure means to seize. It comes from seize. So whatever I'm doing, I stop doing that. So if I'm talking, I suddenly go blank, staring. But if I'm lying down or sleeping, I suddenly wake up and do either jerking or stiffness. So any of those activities is a seizure.
Correct.
Um,
So it reflects something happening in the brain discharges.
that's true. So because of this is rapid, sudden change in the brain activity, which can be primary from the brain or somewhere else.
Okay.
And most people fits what they mean by stiffness and convulsion is motor jerking.
Correct.
Uh, and paroxysm is again same thing in medical terms is you have sudden brief change in brain activity.
Mm-hmm.
So I think better to use because it creates confusion amongst people of what they
Correct.
mean. So
Correct.
better to use proper terminology. So seizures is a perfect thing, and
Correct.
then we can divide further seizures into whether they're epileptic, non-epileptic,
Okay.
brain origin, cardiac origin, etc.
All right. So, Dr. Brajesh, now that we talk of seizures, generally the seizures are divided into different types, like they are provoked, unprovoked, they are reflex, status, etc. So, what are these terms and what is the connotation? Yeah, unmute yourself.
Yeah,
Yeah.
so essentially, basically, seizures are different types, and
Press it a little louder or you come nearer to the laptop, one of the two.
1 minute. I'm full on here. Anyway, so basically,
Yeah, now better. Yeah.
what do you mean by provoked?
Huh.
So provoked is when you have a seizure caused by something. Everybody would know that. So if you have low glucose, low calcium, low magnesium, or you have a trauma or something of that sort, or in kids, you get febrile seizures, which is a kind of provoked epilepsy, provoked seizures. And sometimes it's a little confusing because, for example, cystic there's a type of cystic which can give provoke seizures. So you have edema around the cyst and you get seizures. And then many years later, you may again get the same edema around a dead cyst and you may get seizures. So it becomes again acute recurrent provoke seizures.
Okay.
Generally, provoke seizures means something is there. Anybody from all of us can get a provoke seizure, regardless of whether we have a tendency or not.
So, as I understand, the provoked seizures would not necessarily go into epilepsy. Most of them would recover once the
So
primary
just to,
disease is
just to give
controlled.
you a simple thing, 8% of the population will have a seizure in their lifetime, but
Once in life.
1% will have epilepsy.
Okay, fine. Go ahead. Unprovoked.
Unprovoked is basically when there is no obvious reason, like a bolt from the blue. And this obviously is more significant and suggests that it might be uh, an epileptic disorder, though we do not call it that
Mm-hmm.
with the first unprovoked seizure.
Yes.
And there are certain criteria which we use to decide, because the risk of first unprovoked seizure coming again is about 30% in
Mhm.
most studies. While we call it epilepsy, when you call it epilepsy, it usually means you had two seizures or you had some other abnormalities on EEG or MRI or clinical. Then the risk becomes 60%. So that becomes epilepsy. That means you have an epileptic predisposition, which
Correct.
you see.
Can you also get an unprovoked seizure in a patient who had a CNS insult in the past, like it's not related
Yes,
directly to the
yes, yes. So
injury
that becomes a unprovoked seizure caused by a provoked seizure earlier. The sense damage
earlier?
caused by
Okay.
something.
All right. And
Reflex seizures are basically when something like a sense, like a light or sound or something brings, and they're peculiar reflex seizures. For example, some epilepsies with reading, you can get it. Some certain types of music, or it's called musicogenic epilepsy. So all different things.
Mhm.
Finally, status is, you want to discuss, status means you're going into a state of fairly continuous seizures. Now, I think you want me to discuss the whole of status, or
No, we can discuss a little later. Yeah, okay, when we come to that. All
basically
right.
it comes when, yeah, yeah.
All right. So let's see a clinical scenario. All right. A child has come convulsing to the casualty. There was some fever, cough, and cold for last 1 or 2 days. Some URI like picture, which is so not uncommon in children nowadays. Convulsions were generalized tonic-clonic with uprolling of eyeball, and they lasted for 5 minutes. Parents were in panic. They thought the child is going to die. There was no vomiting. There was no drowsiness. The child was perfectly all right as he had gone to the school in the morning, or he was doing his day-to-day activity. And now he's brought to the casualty. So now how will you manage? So Lokesh, are you there?
Yeah, I'm there. I'm there.
All right. So, okay. So you can answer. So how will you abort the seizure first? I think the first priority is to abort the seizure besides taking care of the A, B, C, D of the resuscitation.
Yeah, absolutely. I think apart from the ABC, they already mentioned. Most of the emergencies today are equipped with midazolam nasal spray.
Uh-huh.
So 0.2 milligram per kilo or approximate weight for the child. So you can do the nasal spray by simultaneously while trying to establish a IV cannulation.
Okay.
And if it is aborted by the midazolam spray, then well and good. If it is still not aborted, we can do the same injection midazolam IV.
Mm-hmm.
And
So,
yeah,
so in past, when we were student, we used to use diazepam.
yeah.
Now we see a lot of people use lorazepam or a midazolam nasal spray. So when you use lorazepam intravenously, what is the advantage of lorazepam over diazepam?
Lorazepam obviously has a much longer half-life, and it works for almost 6 hours and less respiratory suppressive effect.
Mm-hmm.
So I think most of us don't use that as a part of protocol today,
Mm-hmm.
and it will be either midazolam, and lorazepam mainly requires refrigeration to be there. So if
Mm-hmm.
places where refrigeration is difficult, midazolam will be always there, but midazolam is short acting as
Mm-hmm.
compared to lorazepam.
Okay, fine. So lorazepam, what dose would you use if you have to use IV?
Yeah, 0.1 milligram per kilo.
And if suppose someone wants to use diazepam, then what dose they would use?
I have not used midazolam for a long, long time. Actually, I'm
What
thinking,
about rectal diazepam to
yeah,
abort in convulsion?
yeah, I think we have gone away. Actually, US, even still they have rectal diazepam got
Uh-huh.
given, but we are either using nasal midazolam,
Mm-hmm.
intranasal midazolam, or IV midazolam, or IV lorazepam. Only three forms we are using.
So is there any upper dose of midazolam nasal spray, like
Zero point 0.3
0.4?
milligram, zero point 0.3 milligram per kilo.
No, absolute dose, like suppose 80 kilo boy comes or 80 kilo girl comes,
Yeah, so maximum usually we don't go beyond around 10 milligrams.
10 milligram. All right. And can you repeat it in case the child has had convulsion and you are not able to secure an IV? Then
Yeah,
how do you,
after 5 minutes, we ask them to repeat at home. If they are at home, after 5 minutes,
uh-huh.
it's still not aborted, we ask them to repeat the dosage.
Okay, and simultaneously now the child is in casualty, so obviously he's in healthcare. Would you
Yeah,
want to do some investigation in this child,
yeah
or
while we
you
are
presume
placing
it's
it,
going to be a
yeah.
febrile convulsion, so don't do any metabolic, sugar, CBC? I mean, any of
No,
the basic tests you would do or not do?
no, we would draw definitely if sugar should be done in every child who comes in seizing. Along
Mm-hmm.
with that, if the child is febrile, CBP, CRP, and electrolytes at least, because all
Mm-hmm.
these things can trigger seizures. So those
Mm-hmm.
things definitely we do along with SOS urine protein examination as well once the child is stable.
Mhm. So the basic investigations should be done in every child with suspected febrile convulsion. I still remember in Hinduja casualty once our smart resident called up at night saying that one child has come like this, but I find his sugars are low. And next day morning when we went, we also saw some hyperpigmentation around the neck. So he had acanthosis without obesity, and then that roused the suspicion that it's not just simple febrile convulsion. There is something happening in the brain, and MRI actually showed adrenal leukodystrophy. So it is good to not to miss your routine testing always, because you will be once in a while be rewarded by a rare diagnosis. But otherwise, febrile conversion would be one of the commonest reason why such a child would come. All right, Dr. Brajesh, how do you know that the seizure has stopped and the child has no non-convulsive status? Like there is no way you don't have a EEG bedside. Child has not recovered. He's still drowsy. They stop fitting.
Yeah, so usually febrile. I mean, this is a scenario in febrile seizures themselves. The post-ictal period is short, and very often by the time you see the child, the baby is fine.
They have gotten up.
Everything gotten up and everything is fine. But if you have febrile status, it's
Yes.
much longer than the usual seizure,
Mm-hmm.
then it's possible that the post-ictal period may be longer, and usually
Mm-hmm.
it may extend beyond 1 hour, which is a long time.
Mm-hmm.
And if you have continually the child is not waking up and
Mm-hmm.
he has some subtle movements or whatever, maybe a little mouth twitching,
Mm-hmm.
mouth automatism,
Mm-hmm.
or some sort of eye movements and all, then you
Yes.
expect that this is actually non-convulsive status going on.
Correct. So even if the tonic movements have stopped, but if there are still some deviation of eye, some subtle movements here and there, then think that this is not the end of the story.
Correct. And very
Right.
often may have nothing and only prolonged unresponsiveness. So you
All
require
right.
EEG for sure.
Perfect. Dr. Ramesh, please take over. Unmute, unmute, unmute. Dr. Ramesh, unmute. No, now you unmuted. No, you muted again. No, you muted again.
So, Nitin, I got disconnected. Sorry for that.
No
Now,
problem.
yeah. Now, Lokesh, this conversion has stopped already. Child is awake and alert in 30 minutes, I said. On examination, there are no findings on except that mild URI. So now the practical issues. Is it a febrile conversion?
Yes, if the development is normal, and there has been in the examination findings as sir suggested one diagnosis there if the head circumference is normal and there is no large head or small head and other family history of febrile seizures or afebrile seizures, and also you'll have to get into the whether the child had any perinatal insult, a child with neonatal hypoglycemic injury, the fever can just trigger off a seizure. So all those things have to be taken into consideration once the seizures have been stopped, so that you make a decision whether this seizure is been triggered by fever or it's just a febrile seizure.
Okay.
So
Oh,
if
perfect.
the development is normal and there is no other things, then it is just a febrile seizure. If there is a family history of febrile seizure or afebrile seizure, and so those things will be something like GFS plus genetic epilepsy plus febrile seizure plus syndrome or FS plus syndrome. Whereas if it becomes, if there is a developmental issues, perinatal insult, then you are looking at a triggered seizure. The fever has just triggered in a child who had underlying susceptibility to have a seizure.
Correct. Now, Nitish bhai,
So,
is it necessary to admit
No,
this
so
patient?
just
So in
Ramesh,
so-called,
before that, Dr.
yes.
Lokesh, some more. What
Yes,
percent
sir.
of children develop febrile convulsion in general population?
So 1 in 25 children between 6 months to 6 years. So that
Uh-huh.
is 4 per 100 would be
Oh, that's very
developing a
high,
febrile.
4%.
Yeah, yes, sir.
All right. What is simple febrile seizure and what is complex febrile seizure? These are the terms used many times.
Yeah, so simple is something which is generalized in nature and it is lasts less than 5 minutes
Okay.
about by self. So that is usually a simple febrile seizure.
Mm-hmm.
A cluster seizures, focal febrile seizure,
Correct.
are going on for more than 15 minutes.
Mm-hmm.
Then you start thinking of a complex febrile seizure.
What if the convulsion repeats in the same episode of fever? Will you call it complex or it is
Now, within 24 hours, we will still call it as a simple febrile within
okay?
24 hours.
All right. And sometimes it happens that the child is actually afebrile and the child has had convulsion. You are busy in aborting the convulsion and getting some blood test 10 minutes and now the fever is shot up. Will it still be called it febrile convulsion or there has to
That
be
is still
fever before?
that is still a febrile seizure, sir,
That is
because it is rapidly rising. So that is the
correct.
rapidity of rise. So by the time you actually detect the child already has seizures, and then you have within 10-15 minutes the child has
I
a
think
fever.
this is an important message because many times people feel that no, there was no fever at the onset, so it is not febrile convulsion. They do EEG, MRI, this that is not required. Okay, Doctor Ramesh, bhai, continue.
Yeah. Now, Nitish bhai, is it necessary to admit such patients during first episode or subsequent episode? Because many of our colleagues, they admit, some of them, they don't admit. So what is the correct approach?
okay, I think it's a balanced approach, depends individual child and the situation that stage. So if this is first seizure, less than 1 year child or so less than 1 year child, there is no obvious focus of infection, possible CNS infection you want to rule out, or child has background abnormal neurology or development, or you're not sure of the source of infection, or if parents are very anxious, I think yes, this child needs admission. If this is first seizure, but say 2-3 years of age, very typical age, like this child has upper respiratory infection, and very obvious focus, child is very well, quick recover, normal neurodevelopment. In that case, child may not be required admission.
Right. Now, Vrajesh bhai, what about LP? Because we were taught that especially in younger children, pyogenic meningitis can present in any form. So, is it necessary to do LP in first episode of febrile conversion? And if yes, why?
Well, I would see this thing about young children, 1 year old and below. It was really meant for junior residents and all that, because you don't want to miss a diagnosis of meningitis and they may be a little inexperienced. But generally, the kid is sitting up and is absolutely fine and everything else. You would not do an LP at any age, and as long as you're observing the kid for a bit. the time when the LP things comes up is when there's a febrile status epilepticus. So once you have a long seizure going on for maybe 30 minutes or more, then the risk of uh, meningitis increases a bit. In fact, it goes up from about 1% to maybe 10% or so. And even then, most of the times it's really a viral or other type of meningitis, where it's not really. So if you have a kid who's not waking up or had a significant long seizure, you could do an LP in that situation. But remember one thing, if you're not certain, if you're uncomfortable, an LP never hurts. So you should go ahead and do it. So any clinically, if you're not very certain, it's better to, do it and be on the side of caution.
So correct. Now, Rajesh, bhai, most of the parents, especially in periphery, when they come with seizures and after that child is playful, so they generally resist LP. So in that case, if
Correct,
they
I
go,
agree with
if
that. I agree with that.
yeah, so if they go home, then is it sensible to prescribe some oral antibiotics or?
I personally think, I mean, I'm not I've been a pediatrician many years ago, but my general feeling is that most fevers generally don't require antibiotics. I would prefer not to give antibiotics unless there's an obvious reason why you're giving the antibiotics, because the problem is that you might compromise that's why, but that's of course, I leave it to the individual pediatrician to decide.
Right, right. Now, Nitish, bhai, what is the natural course in febrile seizures? I mean, the chances of recurrence in future?
Sure. So as Lucas said, 6 months to 6 years is the most common period where seizures do occur. And I think it depends on the few factors. So younger the age, so if child is less than 12 months, there is high chance of recurrence. So it's a 50% chance of recurrence. But when child grows beyond 3 years of age, there's less chance of recurrence, say around 20%. But also few factors, as we were saying. So if there's a family history of febrile seizures, if there is previous child has previous febrile seizures, or on very low temperature or very rapidly rising temperature child is getting seizures, all those children are likely to get more frequent febrile seizures. So I think again it's a, but in general there is 30 to 40% chance there will be recurrence of the febrile seizure in a given child.
So Nitish bhai, just a subsidiary question.
So
You said the risk factor for recurrence are one of these three, like strong family history, a very low temperature, which is leading to convulsion, etc.
so
Parents want to know when will this febrile current will stop. Is it safe to say that there are last 2 years or 2.5 years the child hasn't had a recurrence? Very unlikely that he will have recurrence now.
that's true. So I think beyond 3 years of age it's less likely, and if the 2 years seizure free, that's
Mhm.
yes, it's absolutely.
Okay, and the one question that really bothers parents is, can the febrile conjure be fatal anytime?
Yes, so any seizure, not just febrile seizure, and that's why the ABC comes everywhere. So mortality can be because of couple of things, mainly because of safety, say fall, head injury, drowning,
Correct.
aspiration, all those things. And second is a febrile status, or because of underlying etiology, infection, and complications from there.
But generally, they are very rare, right? Most
That's
of
true.
them,
That's true.
yeah.
And
So
as you,
though it
their
looks
opening
scary to
statement
the
was,
parents that the child is dying in the home, the reassurance should be that it doesn't happen, right?
absolutely. So most of children do not die. Febrile seizures are straightforward, and if you maintain standard things and safety, no, they should not die.
Perfect. Continue, Ramesh bhai.
Uh, Now, Rajesh, bhai, do you give clobazam prophylaxis for subsequent febrile seizures?
Well, I do, because primarily because of the parents' anxiety. But frankly, there is no definite evidence that it
Rajiv, a
works
little
for sure.
louder. We can't hear you well.
So what I'm saying is, I do that, but
Uh-huh.
the literature is not necessary. One thing is for sure, clobazam, if given in time, will definitely reduce the risk of future febrile seizures.
Mm-hmm.
So given it before the fever starts, obviously half an hour or something before the actual, so at least 20-30 minutes ke baad mein you can get it's unlikely you're going to get a seizure. But
Mm-hmm.
and there is no clear, I mean, abroad, as you know, where parents are a little less anxious and are more willing to accept all this, there's people don't use, so it's not compulsory that you must use it, but generally I tend to use it because all our parents are more comfortable with that.
So, in which dose, sir?
Well, I use much lower doses than I use 0.25 to 0.5, though the doses mentioned are 0.5 to 1. And I think if you give too much, 1 milligram per kilo, it's a big dose. You give it, they get irritable and cranky and then becomes a more of a problem.
So that's per kg per day
yeah,
in two divided doses.
2 divided doses for 3
Oh,
days. 2 to
okay.
3 days. Yeah.
How many days, sir?
2 to 3 days.
2 to
2 to
3
3.
days.
40 days is enough, but sometimes you may go up to 3 days also.
So,
The risk of
Rajat,
seizures is maximum in the first 24 hours. That's all.
correct. Rajat, in past, people used to use Phenobarb. Of course, they used to use Phenobarb for 2 years. That's given up. Now they feel Phenobarb not only sedates the child, but also brings the fever down faster because it also leads to hypothermia. And maybe it will protect the brain more than clobazam. Any such
No.
evidence?
There's no evidence of that.
Okay.
Mhm. Now, how can parents manage next time when seizures occurs at home?
So
How, how do you counsel?
asking me, right?
Yeah.
Yeah.
So basically, I mean, if once you have a fever, and that should be 99.5 and above, or 2 degrees above the normal. So there's a little variation what exactly is fever, but 99.5 is considered the. If you have that, you start the clobazam. If you are okay, if you're not giving clobazam, fine, but you be careful at that time. You might get a seizure, and then you have to use your intranasal midazolam. But basically, that's it. There's the only problem is sometimes the fever comes after the seizure, like somebody mentioned. And in those situations, what I tell them, because they keep asking these questions, what I tell them is if the baby is very sick, or I mean, he's got some cough, cold, fever, I mean, not fever, but cough, cold, etc., and he's feeling a little unwell, you start taking the temperature, and if
Correct.
the temperature shoots to 99.5, you give it.
Correct.
Usually these things work, but the most important thing is even if he gets a seizure, so what? Doesn't really matter.
So when they rush to casualty, or how far they should wait at home?
If the seizure is over, and one of the ways of finding out seizure is over is, of course, they stop jerking, or the eyes. Sometimes, your seizure may not have jerking, you may just have widening of the eyes or something of that sort. Any case, as soon as the eyes are closed, the baby appears to be sleeping, is fine. Then if he wakes up fine, then it's absolutely normal. And this is a recurrent febrile seizure. Most of the time they can manage it, but what?
So
Correct.
one question, the midazolam nasal spray, maybe Dr. Nitish can answer. Can you keep it outside the refrigerator or it has to be refrigerated?
So I think adding to what Udani sir said, so one is medical manager of seizures, but what we mainly do, as sir will agree, is maintain, I mean, relieving parents' anxiety. So if parents are comfortable how to manage the child, that's more than sufficient. Regarding midazolam nasal spray, of course, it has its few rules. If because most of parents, they come back and say it's not working. So yes, it should be covered or in the room temperature, but not the hot temperature.
Correct.
Especially western part of India, we are very hot temperature, and
Mm.
it does get evaporated. Second thing is practical thing. One is a temperature. People do keep somewhere in the purse and say middle of night someone says it's in my purse, find my purse. People may not able to find the purse, but if say it's in the door fridge, means fridge door, it's easy to find someone's fridge even in the as an unknown person. So
Correct.
door fridge is a best place because it's cold temperature, easy to find. And also when you're using midazolam nasal spray, make sure you prime it. So you remove the cap, press once or twice so that air is out, and then
Mhm.
actually spray starts.
Correct.
And also, of course, you're putting the child in the recovery position to start with. But while putting the spray, I think child's neck should be either lifted so that when you spray, it directly goes into neck. Otherwise,
Correct.
if the spray is vertical down, the drug will not come in. So
Correct.
if these common things are done, then usually spray is very helpful.
Then what strength of midazolam nasal spray you prefer? Because they come in two different strengths.
That's true. So I think for young children, 0.5 milligram per puff, that's the base dose. And the bigger children, so more than 8, 10 years, 1.25. And you are asking the dose, I think the zero point 0.2 is partly fine, but
Correct.
then people don't remember actual weight. And so there's an easy mnemonic. So
Mhm.
every 5 kg,
Mm.
you 0.5 milligram wala spray, you give 1 plus 1. So up
Correct.
to 5 kg or around 5 kg, 1 plus 1 spray.
Correct.
Around 10 kgs, 2 plus 2. Around
Correct.
15 kg weight, 3 plus 3. around 20 kg is 4 plus 4, and then bigger children 5 plus 5 or 6 plus 6.
Correct, right. Okay, so I think that's important because you may mistakenly give the same number of puffs from a 1.25 milligram strength spray, then you are actually dosing 2.5 times more. So
That's
that you have to
true.
be careful, right? Which one is it? Okay. Okay, go ahead, Dr.
Yeah,
Dr.
now coming to you, Lokesh, what is atypical febrile conversion? Lokesh?
Lokesh, I think we have lost him.
Yeah, anyone can
He's
take.
not.
Anyone
So we
take.
have
Rajesh.
Rajesh can take. So Rajesh, he mentioned. So Dr. Rajesh, he mentioned. Dr. Lokesh mentioned about this Jeffs plus and Draves and complex and atypical. These are the words which are used very
No, no,
loosely. So
that's just,
what are these? Huh?
yeah, basically simple and complex.
Correct.
Typical and atypical were older terms which have been now uh,
Given up.
not used. Yeah. So simple is basically brief, generalized, and happens once in a day. Complex is more than supposed to be 10 minutes, but I would say more than 5 minutes. Focal, and if it happens multiple times a day.
Can't hear you, Rajesh. Sorry.
So multiple times a day
Ah.
or
Hmm.
happening complex means either it's a long seizure more than 5-10 minutes.
Uh-huh.
If it's a focal seizure or if it's multiple times a day, that's complex.
Correct.
The reason for this is because the prognosis differs.
Correct.
Most complex seizures also do well. Complex febrile seizures do well. But the risk of epilepsy in the future is higher than if it is a simple febrile seizure.
Correct. Okay. And what is this Jeffs plus and
Yeah, so then if the 6 months, so basically children who have seizures going on beyond the usual 6 years, so you may have up to even 8 years, 9 years,
correct.
10 years, or if you have febrile seizures, so those are called febrile seizures plus.
Correct.
Febrile seizures plus would be also seizures which are febrile and may have afebrile seizures as well, or may have other types, myoclonic seizures or absence seizures or whatever. So all these come under this group of febrile seizure plus.
Okay.
As long as they have fever. So do not
Correct.
fever at that time. It comes into the broad rubric of Jeff's plus. So Jeff's plus
Correct.
is actually a familial disorder.
Correct.
Multiple family members some have epilepsy, some have febrile seizure, some have febrile seizure plus, that kind of thing.
So if you have FEBS plus, I mean, suppose 9 years, the continuing conversion with fever, you keep on giving the clobazam prophylaxis to them till
Well,
10, 11, like what is it?
I do that if there is no afebrile seizure.
Correct.
Once afebrile seizures come, then and obviously there's no clear protocol on this. I mean,
Correct.
patients who are 8 years, 9 years old, you always worry that maybe there's an underlying reason why they're having the febrile seizure. But if everything is, you might investigate that patient a little more in detail. And if there is nothing, you call it febrile seizure plus, and you give them the option that yes, you could just wait with clobazam prophylaxis as long as you're okay with it. And
Correct.
that's what I do at least.
And lastly, there are children who have had DPT vaccine and had fever, high fever and convulsion. And then every time you give it, it happens. And the the second child saw the same thing. And they might have lost one child of similar illness in the past. And what are these symptoms? They are like channelopathies. They are what?
Yeah, well, basically, many of them, the vaccine encephalopathy is really a condition which is now probably SCN1A related. So many patients who have vaccine related seizures and encephalopathy and all that have this sodium channelopathy, which is the SCN1A. And usually it comes early before 6 months, so maybe even
Correct.
3 months and all that.
Yeah.
They have hemiclonic, usually one-sided, but also bilateral seizures. They have prolonged seizures going on status. They may go into encephalopathy. They have frequent seizures. In the first year, they're okay. But in the second year, usually the language gets a little delayed. They may develop autistic features. And the seizures is a real problem. So if you see a patient who's below 6 months and getting long seizures and all that, please do the SCN1A or send to a pediatric neurologist, because this is a
Correct.
case where you need to have anti-epileptic treatment and certain epileptic medications, like, for example, carbamazepine or phenytoin, etc., are contraindicated. So it's
Correct.
better to refer this kind of patient to a
Perfect. And suppose the previous child had a similar illness and was found to be positive, would you investigate the next child
doctor.
before you give the pertussis vaccine?
Yeah, but uh, yes, and just a little caveat over here. Dravet syndrome, usually family history is negative.
Hmm.
So that SCN1A, which is the gene, has different types of syndromes. One of them is, of course, Dravet, which is a well-known, but usually a single person is involved because it's a de novo mutation. So it's not something which is inherited from Frank. But if it's inherited from the father or all that, you may have a condition called Jeff's plus, which we talked about.
Correct.
There is no retardation. There is just having febrile and afebrile seizures. So
Hmm.
so the genetic epilepsy, febrile seizures is a family of diseases in which one is Dravet's, one is febrile seizure plus, one is other myoclonic seizures, etc. So I
Correct.
mean that's the kind of so Jeff's is really a diagnosis in a family, I would feel.
Correct.
Now, Rajesh, role of EEG or neuroimaging, like as a general pediatrician, should I subject or should I refer to you, and when you subject for these investigations?
We are coming back to the first case, not these Jeff plus and the Draves and all. Simple
Yeah,
febrile seizure.
simple febrile seizures, no EEG, no MRI.
Okay, fine.
Great. Nitish bhai, now
I
do
think this is
you
an important message, Ramesh bhai, that this is a common confusion for the pediatrician and the parents also.
that
So
is
they've
that
heard of all this. Should I do MRI? So I think we should say no, there's no need unless there is some complication or a afebrile seizure or something which is beyond the typical febrile seizure. Yeah, go
yes.
ahead.
Nitish bhai, now last in this case, do children with febrile seizures have higher chances of developing subsequent epilepsy, which Rajesh bhai partly said? Any risk factors which can predict it?
Yes. So as Udani sir said, complex febrile seizures is definitely a risk. So early onset of focal seizures, prolonged
Mm-hmm.
seizures,
Mm-hmm.
or there is a family history of febrile seizures. Also, if child has background abnormal neurology or development, so all those things will increase a chance. And again, it's a combination of factors. So if it's single factor, the overall risk if someone has febrile seizure in population, chance is around 1%. And if someone has febrile seizure, chance will be around 3%. But if you have multiple factors, you may have to 50% chance of developing epilepsy.
Mm-hmm.
Right, correct.
So which means even a simple febrile seizure without any complexity does have a more chance of epilepsy than a general population.
Yes,
It's like three
slightly
times
raised.
more. Yeah,
Yes,
three times
slightly
more.
raised. So, but simple febrile seizure we will not kind of worry about that much. But complex febrile seizures and other things definitely
But
yes.
because this is a question that parents ask that I'll give it till 5 years, as you said, doctor, but will you develop epilepsy in the future? So that's the question we need to answer. And
Absolutely, sir.
more the risk factor, you have to be a little more telling them that yes, there are chances and look for that.
That's true.
All right. Is there any way, Dr. Rajesh, that you look at the hippocampus if you've done an MRI and look at the volume, and that's a predictor for a future epilepsy in children with febrile seizures?
I mean, if you basically you're looking at the other way around. So if you develop a epileptic disorder, I mean, you're right that sometimes hippocampal abnormalities precede epilepsy. Sometimes they are caused by prolonged febrile seizure.
Mm-hmm. Mm-hmm.
But you can't really predict in the sense that I don't think if you have epilepsy in the future and you have a history of febrile seizure, you would examine the hippocampus very carefully. Yes.
Okay. All right. So now let's switch to the same child, a different scenario. So, Dr. Rajesh, suppose this child had not
Oh,
responded to the
Lokesh is
first.
gone or what?
Yeah, I
Lokesh?
think he's probably disconnected. I mean, he'll come back. It's okay. We can continue with two of you. You are equal and enough maestros that I have in my armamentarium. So, Rajesh, how long will you wait for the seizure to stop with your first dose of lorazepam, whether it is midazolam nasal spray or a lorazepam given IV, before you think of giving second dose? And why you wait for this long or don't wait for this long?
Well, if the patient is coming convulsing to the casualty or to your clinic, I mean,
Mm-hmm.
depending on how long he's traveled, you don't know exactly how long he's had this seizure going on.
Correct.
Giving benzodiazepines, one of the problems very commonly seen is people underdose.
Correct.
First of all, you must give a correct dose, and this is something which I think somebody has already mentioned, the different doses which you must give properly. So in 10 minutes, this is 5-10 minutes. We wait 10 minutes, and if it's not stopped, you would give a second dose.
So second dose of what? Same drug?
Yes, benzodiazepine. Some people go to a different drug completely, so there's no
Mhm.
fixed protocol. But one
And
of
same dose, 0.2 mg per kg of
yes, yes,
lorazepam.
what the maximum dose which is allowed. Yeah,
Okay.
you cannot give more because then you might just have a problem of respiratory depression, etc.
Okay. And suppose he doesn't respond to the second dose. Now, how long you wait?
Well, you wait for 10. See, benzodiazepines will take about 5 minutes to work.
Hmm.
Especially they work a little less effectively if the seizure has been going on for more than half an hour. In that situation, so 5-10 minutes you wait and you give. See, this timing is all very difficult
No,
because
I understand, but that's a
so
practical issue where
basically, yeah.
pediatrician
And
wants
then
to
you go to
know.
the next, yeah. So you can give either phosphenitoin or you
Okay.
can give levetiracetam.
Okay, we'll come to that. When do you call
Yeah.
it status?
Status is basically the operational definition is there are two time slot T1 and T2.
Mm-hmm.
T1 is basically when you intervene with your aggressive treatment, and that is basically 5 minutes.
Mm-hmm.
So T1 is that. T2 is the time which is 30 minutes when there's a chance that you might damage your brain at that time. So the risk becomes high after T2.
Mm.
Therefore, so another way of looking at it is after 5 minutes is called impending status.
Mm-hmm.
So 5 minutes to 30 minutes. And after 30 minutes is called established status.
Correct. All right.
So
So,
basic
doctor,
problem is all this is very difficult because half the time you don't know how much time the patient has been convalescent.
I know. And you can never rely on the history of the parents because for them, 1 minute looks like 1 hour.
Correct.
They may over exaggerate the symptoms. All right, Dr. Nitish,
So,
can can the status be non-convulsive? What is non-convulsive status? How do you know it, and how do you then treat it?
sure. Yeah. So status can be most of what we see is convulsive, but there's so many children in A&E or after status or after febrile seizures, they may be non-convulsive status. So it can be clinically, we can see child is remaining drowsy,
Okay.
abnormal eye movements like either
Yes.
squinting or
Mm-hmm.
jerking as a nystagmus, or
Mm-hmm.
the parameters, your ABC means we can say it's fluctuating heart rate.
Mm-hmm.
So all those things will be suggested child is in non-convulsive status. But to
Mm-hmm.
stem that, you will need the EEG.
Mm-hmm.
So it's clinical suspicion confirmed by the EEG, on-site EEG.
Okay.
And your question to that is, sir, will add to that. Of course, status is an emergency. So you are trying to use in emergency your based people, so based drug,
Correct. So
based
you
route,
so
and
so
based
basically
dose.
the non-convulsive status will be treated same as the status,
Yes,
convulsive
but
status.
the duration, as sir was saying, T1 and T2. So for
Mm-hmm.
for convulsive status, T1 is 5 minutes, where you want to act, and T2 is 30 minutes. By that time, if you don't, you have not control the seizures, brain damage is imminent.
All right.
Non-convulsive, it's difficult. So usually people say T1 is around 20 to 30 minutes. So by 20 to 30 minutes, if you are not working, so by that time you should be acting. And
Mm-hmm.
T2 is likely to be 60 minutes or 90 minutes.
Mm-hmm.
So you have some leeway in the time.
Leeway. Okay, so you have more time at your disposal before you take the drastic steps as to what to do next.
That's
All
it.
right, Nitish, you can also take this. There are a lot of terminology, status, NORS, fires. I mean, what are all these terms and are they interconnected or they are different terms?
No, I think I mean there are different terms, but as we know, I mean some of the things we don't know etiology, and as we know etiology, we get more precise names or renames. So as I said, imminent status, established status, and or refractory status, then supra-refractory status. So if it goes beyond 24 hours, it will be supra-refractory. Beyond
Mm-hmm.
1 hour, it will be refractory. So so fire is the initial technology was because of fever or some infection triggered
Mm-hmm.
status, and that is so bad. Brains, neurons, or networks keep firing, and
Mm-hmm.
they it's like the wildfire in the bush, so it
Mm-hmm.
keeps spreading. and it keeps allowing other networks, and your seizures control becomes more and more difficult, and eventually you get brain damage and multi-organ failure. Norse is again, now we think it's a immune process. So post-infection, it's an immune process, and you quickly want to control seizures. And if you're not able to control the seizures, beyond that, you also start the immune modulation earlier.
All right.
And
Okay.
that's Norse.
Right. Okay. So now let's take like a rapid fire. The conversions have not stopped after the second dose, as I said. So what is the alternative drug and their doses? So Dr. Nitish, levetiracetam dose and route and
Okay.
rate.
So the good thing is all the protocol now, it says drug, a dose to remember is 20 mg per kg over 20 minutes. So
IV.
it's so basically it's to simplify it nationally. So you can use levetiracetam 20 mg per kg, slow infusion of 20 minutes. You can
Okay.
go up to 40 mg per kg as well.
Correct.
Next can be
Okay. Rajesh bhai,
sorry.
phosphenitoin or phenytoin?
Well, preferably phosphoenitoin, because
Advantage?
advantage is one, it can be given intramuscular. Number two, it can be given faster IV. It's a prodrug, so you can give it as much as 3 milligram per kilogram per minute IV. And
How much you
phenytoin,
said dose? Just repeat.
no, the dose I'd give you, but
Ah,
it's basically 20 milligram per kilo of phenytoin, of what is called phenytoin equivalents.
equivalent.
20 milligram per kilo of phenytoin is equal to 30 milligram per kilo of
Phosphenol.
phosphoenitoin. But you don't use phosphoenitoin in phenytoin in milligram per kilogram. You use phenytoin equivalents. So
Correct.
you use 20 milligram phenytoin equivalents of phosphoenitoin, and that can be given as fast as 3 milligram per kilogram per minute.
So over 6 minutes, that
Yeah,
means 6 to 7 minutes.
it
All
depends
right.
on what your weight of the child is, but
Okay.
and you can give it IM. Suppose you can't get an IV also.
Correct. Nitish, can you use phenobarb? And if yes,
Absolutely, sir.
dose and route.
So phenobarbital, again, fantastic drug, especially young children, works very well at any age, and dose 20 mg per kilogram, slow infusion of 20 minutes. But again, if you're giving phenobarbital after 2 benzodiazepines, be careful, child can have respiratory depression. So have your bag and mask and other things ready.
Right. Dr. Brajesh, lot of IV valproate used nowadays. So dose and how fast?
Well, you have to give it as an infusion. I think it's about 30 milligrams per kilo, but it has to be given as the infusion. Because if you give it very fast, then you can get hypertension and all that.
So over what? Half an hour?
No, 15 minutes, 10, 15 minutes.
15 minutes. All
But
right.
it's very useful for non-convulsive status.
Correct. And if suppose
Levetiracetam and valproate are very useful for non-convulsive status.
okay, and if nothing helps, then what now? Paralyze the patient.
No, then you go to the third thing. You go to midazolam drip. So
Midazolam drip. Okay.
the next step. Paralysis is only meant for to sedate, get the patients a little quiet, and because by this time usually intubation has already happened.
Correct.
And your
So the Midas drip dose and
Yes, sir.
Nitish.
I will help, sir.
You can give a maximum. You can give a loading dose, and then you give a maximum dose. Every 15 minutes, you go for increasing. If I remember right, it's 18 micrograms per kilogram per minute or 2 milligrams per kilogram per hour.
Okay.
So that is the way I look at it. The loading dose, I forget the exact.
Sir, it's 0.5 per kg. So boss is boss.
I don't know.
No, that's because once
resolution.
that happens, then Rajat doesn't manage. Sundu manages.
Absolutely.
But you are understanding one thing, that every 15 minutes, if you are not getting
Escalation.
you escalate till you reach, if you're using milligram per kilogram per hour, up to 2 milligrams per kilogram
kg per hour.
If you're
And
using
this is, of course,
microdose,
in a intubated child with controlled ventilation and everything. Yeah, right.
But
So
also,
we,
sir, sorry, sir.
yes, Nitish.
So
Yeah,
what
go
sir
ahead,
has said
Nitish.
is very important, that like if you're in ICU, you may have done even intubation, thiopentone, etc., etc. But
Correct.
this is very helpful in peripheries where you're waiting for ambulance to come. You don't have your own ICU, and you're waiting for someone to come. At that stage, midazolam infusion does not cause respiratory depression immediately.
Correct.
So it
But you
takes
should still be ready to
yes, so
intubate
you have to be
if
ready
required.
with bag and mask, but at
Correct.
least it can buy 1 hour or 2 hours till your
Correct.
ICU team comes to retrieve the child.
Correct.
Absolutely agreed. Absolutely agreed. Only on the if you combine it with phenobarb or something, then you might have a
Yes.
problem. So I would say that phenobarb you should not use in the second line. I would use levetiracetam or valproate or
Okay.
phosphate.
So I'm going to repeat. You give first dose of lorazepam, wait for 5 to 10 minutes. If no response, you give second dose of lorazepam, again wait for 5 to 10 minutes. If no response, then you need to add the second drug, which can be either levetiracetam or phosphenitoin. Both are safe, right? And then if
Or
that is, yes, if that is not help, then in a non-convulsive, valproate is a choice, but you can use it even in a convulsive status, right?
in the convulsive status, you can either use levetiracetam, phosphenitoin, or valproate, but that
Correct.
depends. And don't keep on using one drug after the other because there's no point. Then you go
Correct.
midazolam straight.
And then and you could use the old very important drug phenobarb before you switch to a midazolam drip, intubation, and then maybe paralysis. Now the question is, each of these drugs are given again. Like suppose you said you wait for 5 to 10 minutes after the first dose for the second dose of lorazepam. Wait for another 5 to 10 minutes between second dose and the first change of drug. After the change of drug, how long you wait for each subsequent change of drug? 5 to 10 minutes the same or?
Yes, sir. So you wait up to, because your infusion is lasting for 20 minutes. So usually what happens, you
Hmm.
in the ICU setup, it will be you're given your sodium valproate has started. Then you are asking your nursing staff or team to prepare next line. So
Correct.
it's ready to be infused after 20 minutes if seizures
Okay.
have not stopped. And
Okay.
what you said in the second line, Nitin sir, is especially for febrile seizures or febrile
Hmm.
status.
Hmm.
If someone is known to have SCN1A or febrile status,
Mhm.
better to use sodium valproate than
Mhm.
phenytoin,
Correct.
because phenytoin phosphate may not help that
Absolutely.
much in febrile status.
Yeah.
It will
Rajesh, you
worsen.
have anything to add
It's
about the
of course.
febrile status?
Yeah, I think it'll worsen it. You're absolutely
Yes.
correct. So
Correct. All right.
things like uh, space for phenytoin, etc., is contraindicated if you're febrile. Don't give it at all because you might
Perfect.
be having a problem. You don't know, and therefore the best thing to do is don't use it.
Okay. I think we have discussed for 1 hour up to febrile convulsion and management of a seizure in a day-to-day practice. Now let's move to the last part. And let's say another scenario. A 4-year-old child has come with history of seizure without fever. Okay. Or any illness preceding to this convulsion at home. Now she is completely conscious by the time she reaches your clinic or your casualty in the hospital. Now, how do you proceed? What points Nitish Bhai in the history and the family history?
Sure, sir. So basically, we are talking about unprovoked seizures.
Unprovoked seizure
Yeah.
without fever, without
Welfare.
any other. You are
So I think we have to look for the possible causes for the first unprovoked seizure. And as any pediatrician, as any doctor would like to start with the, and because child is stable, we have sufficient time for the history and things. So
yes.
starting from the parental or birth history. So like a preterm, means IVH, HIE, hypoglycemia, sepsis, all
Mhm.
those things are
Mhm.
very common things in our country.
Perfect.
Even the hypocalcemia, so all those kind of things.
Correct.
Family history you would like to know, because if there is a known child with a febrile seizure, so gaps plus will be the first presentation,
Mhm. Or
or
a family
even
history of afebrile seizures or
febrile seizures,
epilepsy. Mhm.
epilepsy in the family. Then even the development, how the child is developing, any neurodevelopmental disorders, hypotonia, or any consanguinity in the marriage family,
Correct.
because you have more chance of metabolic disorders,
The
uh,
neuroregression.
neuroregression. So again, that decides your primary etiology,
Mhm.
and also, sometimes you have to look which area is coming from. So suppose they're coming from northern India,
Mhm.
that still maybe first seizure, but may have some lesion like NCC or those kind of
Uh-huh.
things.
Mhm.
You want to examine thoroughly, so head size, microcephaly,
Yes.
dysmorphism, say Down syndrome, etc. Today,
Correct.
uh, neurocutaneous markers, you may have first seizure usually at early age, but
Mhm.
all those things. So I
Correct.
think as a thorough history examination will usually guide to something possible,
Correct.
and that definitely adds to your clinical diagnosis.
Rajesh wanted to say something.
Yeah, I just want to add, I think when the patient first comes to you, you have to take a very detailed history of the event from a
Hmm.
person who's seen it.
Correct.
So you are the historian, the person who's seen it is the witness.
Correct.
You have to sometimes we even call the teacher at school,
Yes.
it may have happened at school, because very often things like, for example, syncope in adolescents
Mhm.
is diagnosed as seizure because they sometimes they have a loss of consciousness, they have some tightening of the limbs, maybe a couple of jerks. So all that is possible in syncope as well. It's called convulsive syncope.
Correct.
Or in a young baby, it could be a shuddering attack, or it could,
Mm-hmm.
self. I mean, so basically, a video, of course, would be the best. But in the first attack, people don't. But if the eye during the episode, if the eyes were open,
Correct.
no obvious contact, they would not listen, or they had a post-ictal state or something of that sort, then you're more sure it was a seizure. So
So
first,
what precipitated the
Event.
seizure?
yeah, well,
All right.
precipitate in the sense exactly. Syncope, for
What
example.
was the child doing that time? Did he fall?
Correct,
Did he
correct,
injure himself?
correct. Did he have
Did he
any
had...
aura? Did he have a feeling
Yes.
something is happening? Because syncope
Right.
very often has an uncomfortable feeling, which happens more. Many
Correct.
people may have had syncopes. You feel
Correct.
restless. You feel that abdominal ping. You feel dizzy. You feel darkness in front of your eyes. All
Some
those,
autonomic disturbance.
you have to find out all that from the history, and then
Correct.
come to it, because everything else, EEG, etc., is all really maybe normal, may not help at all. So that kind of thing. So your
Yeah.
witness story is most important.
And I think tell the parents or the caretaker that next time it happens, they must definitely take a video. Everyone doesn't become panic. One of them can manage the child convulsing, the other can take a video. But I know a parent where we said that, okay, you take a video, then whole night they were awake. Will the child convulse now? So I will miss taking a video. So we have to tell them that they have to be moderate in their approach and not necessarily that they have to remain awake just to record that second seizure. But I think Dr. Lokesh is back. Lokesh, are you there? Dr. Lokesh?
I don't think he's there.
Yeah, I can see him, Lokesh Lingappa, but he's muted. All right, we'll continue. So we said, Lokesh, you are there? Lokesh? Lokesh, are you there? I think we missed. It doesn't matter. So let's continue. So we have a 4-year-old child, no fever, no precipitation of any illness, otherwise well developed. Examination with nothing. That's common 9 out of 10 times. This will be the thing, and he has stopped converging by the time he has come to you. Now the question is it going to be into epilepsy? What investigation do you do? Unlike febrile conversion, where we know definitely don't need to do beyond the routine test. Let's see what investigation. So Dr. Rajesh, EEG, yes, and if yes, when?
Uh, I think first unprovoked seizure and EEG would be a good idea. Generally do it after 48 hours.
40 hours, because if you do it immediately, post-ictal changes
Yeah,
may...
your spikes, etc., may not be seen. So 48 hours is a good time. Anyway, it's not urgent.
And it is
Your history, remember, your history is what diagnoses the seizure, not the EEG.
correct. And awake EEG or
No, always sleep deprived.
sleep deprived.
So that's you
Correct.
become sleep a little late and get up a little early, and then come and sleep in the EEG lab.
Correct. Nitish bhai, we hear this epilepsy protocol MRI. I do an MRI, goes to Rajesh, he said, "Arey, kya MRI करके लाया? Epilepsy protocol नहीं किया." What is the difference in an MRI and an MRI with epilepsy protocol?
Sure. So
And why?
routine,
And why?
so routine MRI and routine things, I think still MRI brain 1.5 Tesla plain is absolutely fine.
Mhm,
But when you're looking for specific lesions, so
mhm,
1.5 Tesla plain MRI will pick up majoritative lesions, big lesions, and in periphery that's what's available.
mhm,
But MRI, I mean, epilepsy protocol, it's more high resolution. That's one thing. There are
mhm,
more added sequence. And third thing is there is usual MRI slices are say of 0.5 centimeter thickness, means that thickness.
mhm.
Here it's 0.1 millimeter thickness.
Okay.
And especially if you don't recommend, otherwise adults they take temporal, because temporal is a very common area where they
Correct.
get seizures.
Mhm.
So it's a high resolution, more sequences and more thinner slices,
Correct.
especially in
So
temporal
how
region.
does it help? I mean, what
Sure.
more?
So basically, epilepsy protocol is mainly, usually we get the second line will be epilepsy protocol MRI, because if you are missing out any tiny lesions, focal
Okay.
cortical dysplasia, or
Okay.
so those things will be missed in that 0.5 thickness. But
Mhm.
here you pick up small lesions as well.
Okay. Rajesh, when do you do a video EEG?
Well, there are two situations really. One is, of course, we do it in patients who have drug refractory or drug resistant
Okay.
epilepsy. That I think by that time, usually it should be in the neurologist's or
Correct.
epileptologist's hands, because those kind of things are best done by people who are doing it regularly. Sometimes video EEG is done if you don't know exactly what a spell is. So what's happening? So when you have a paroxysmal episode, paroxysm just means that it's come suddenly and gone suddenly. So the paroxysmal episode could be a seizure, it could be something else. Only if it is happening frequently. For example, you have a child of autism who is now having these staring spells. Now, with autism, very often they go into their own world and they stare. And sometimes they're thought to have maybe he's got some kind of absence seizures or something. But it's happening every day, or he's jerking or something of that sort. Even a normal kid could be shuddering or whatever. You're not sure. In that situation, a video EEG is very useful, but it's happening daily.
Correct.
It's happening infrequently, you can't do a video EEG.
So which means, as I understand, when you do video EEG, you record the actual paroxysm video.
Exactly.
And at the same time, you corroborate with what's happening in the EEG.
Correct.
And then
Now, the other advantage of video EEG is that even if you don't see a event, the amount of data you take in. So, for example, normally the EEG is about 20 minutes, 30 minutes. Suppose you do a 2-hour or a 4-hour or a 6-hour or you do a 24-hour, the amount of data you have is a lot more.
It is akin to the Holter monitoring for heart.
Yeah, it's a higher chance of picking up what are called interictal epileptic discharges.
Correct.
So that will tell you that this is probably whatever happened was a seizure, even though you not picked it up, because you find that discharges.
And typically you do video EEG for what, 24 hours or 48 hours? Or
depends.
Before you give up?
It depends on what you're doing it for. So for example, for adults, doing for surgery or something, you might even do it for 6-7 days. But if you want to do it for a patient who's got infantile spasms, you might do it for a few hours. If you're not suspecting infantile spasm, then you're not sure.
All right, Rajesh, you can also throw light on the advanced neuroimaging, like a SPECT scan or a diffusion restriction imaging, etc. What are they helpful in patients
these are
with
all
epilepsy?
things which are only important when you're doing epilepsy surgery.
Okay.
So let's see what you're trying to find out in epilepsy surgery evaluation. One, you're trying to find out where the episodes are coming from, where the seizures are. Are they coming from one epileptogenic network, or are they coming from multiple networks, or what have you? So your video EEG will help you in that. And where they are spreading. Second is you're doing high resolution volumetric MRI. So what you do is you do 3D acquisition of the MRI, and which tells you can actually look at the MRI continuously.
Correct.
At what Dr. Nitish was talking about, cortical dysplasia or some other rare lesions, etc., because they could be the substrate causing the drug-resistant epilepsy. And if you find that, it helps you, because now, if you have a definite lesion from their MRI, your chances of epilepsy surgery being successful are very high.
Correct.
It's a MRI negative, and that MRI negative you take with a pinch of salt, because you might be MRI negative in one radiologist's eye, and the other one you might find a lesion. And the third thing is, suppose you find the MRI negative, you don't know what's happening, you still want to do surgery, because this is not that you cannot do. Then you do other nuclear imaging.
Correct.
The next step would be a PET scan.
Correct.
PET scan is for metabolism. So all epileptogenic networks or epileptogenic areas are hypometabolic generally. And that you can pick up if there's one area which is hypometabolic, then you can look at the MRI again and check. There are things like SPECT scan, which is another type of, it's not a very specific kind of thing. It's nowadays used less and less. And finally, there's something called MEG also, encephalography, which is done in 2 or 3 centers in the whole country, and where you try to find out deeper epileptic discharges from deeper structures, which are then put on the MRI, and you can actually find out where exactly the problem is. So all these things are very high technical. Obviously, you should just know that these things are basically, pediatrician should know that epilepsy surgery is available.
Correct.
Is available, and what are the, you must refer any patient with drug-resistant epilepsy, you must refer to an epilepsy center.
Correct. So now the question, Nitish, when do you label this child that he's epilepsy or is not epilepsy? First, unprovoked seizure in an otherwise completely normal child, what history, examination, or a family history?
Sure, sir. So basically, ILA is our MIBAP who dictate this thing and their guidelines. So what it says, if you have 2 or more unprovoked
International
seizures.
League Against Epilepsy.
Yes, International League Against Epilepsy. So it's a 2 or more unprovoked seizures,
Mm-hmm.
or a single seizure
Mm-hmm.
where you have high chance of recurrence.
Like
And if
what?
I,
Like,
if I say two classical examples will be, say, NCC, neurocystic sarcosis. If this is 4-year girl coming from
mm-hmm.
UP, and if she's NCC, I'll still label this as a
Mm-hmm.
epilepsy, because there's a high chance she's going to develop epilepsy, or she has
No,
a cortical malformation or some lesion.
correct.
Other
Or
thing
some
is,
past CNS insult which was silent and now suddenly has come out with an unprovoked seizure.
absolutely, sir. And
Mm.
that's very common in our country with the NHBI, hypoglycemic brain injury, where
Correct.
the child was 3-4 days, bit irritable, not feeding well, and
Mm-hmm.
there's no documented sugar or admission. And
Mm-hmm.
actually, this is first unprovoked seizure, but it's
Mm-hmm.
because of NHBI. And that's where, as sir said, good history, background, examination, and your clinical information can guide to something. So in
Or if,
those cases, it will be labeled as epilepsy.
or if this first unprovoked seizure is fitting into one of the epilepsy syndromes
Syndromes, that's true. So
or
select
myoclonic
childhood
seizure.
absence epilepsy, and
Mm-hmm.
they may present with us as a first seizure, so called, but they may have unwitnessed seizures in the night or other times.
Correct.
So
Correct.
it may be first presentation, but not actually first unprovoked seizure.
Correct. So, Brajesh, will you treat this child now with long-term AED after like he has stopped convulsing? So you are not even giving lorazepam. Now the parents want to know ये वापस होगा तो अभी दवा देना चाहिए, how long, which drug, etc. With the first episode and with the second episode.
No, I mean, first of all, let's just understand what anti-seizure medications do. By the way, nowadays called anti-seizure medications.
Correct.
Just to confuse.
ASM.
Or
ASMs.
they keep changing the some now ASD means autism spectrum disorder, and ASD also means anti-seizure drugs. In any case, so this is what do they do? They are essentially symptomatic
Correct.
treatment. So it's like treating a cough with your dextromethorphan.
Correct.
They don't, many of them don't have any effect on the EEG. They are not anti-epileptogenic. So they don't
Correct.
they reduce the risk of seizures. They don't reduce the risk of epilepsy happening, worsening in the future or anything of that sort. So that's why, for example, if you have a child who has, normal kid who comes with 2, 3, something like what was called before BECT, now it is called SELECT, SLECT, limiting epilepsy with centrotemporal spikes. We would give no treatment at all, and if they are okay with it, don't give any treatment, even if he gets 1 or 2 attacks later on, because the risk is small.
Mm-hmm.
They may have a few attacks. But if there's a patient who has, say, a patient who comes with cerebral palsy, or a patient that comes with, some sort of focal cortical dysplasia, unfortunately he has that, or something of that. So if some lesion is there, then the risk is higher. So you give treatment. If your EEG is abnormal, except in the benign epilepsies or self-limiting epilepsies, the EEG is abnormal, and how abnormal it is will also decide whether you want to insist on treatment or not insist on treatment. So it all take, but usually I do not like to treat the first unprovoked seizure.
Correct. So, but will you do an EEG and an MRI after the first provoked
EEG
seizure?
and MRI, if it is showing clear-cut abnormalities which you suspect, will have a higher risk, because it comes to about the average risk is 30% the first seizure. If the MRI EEG is abnormal with the first seizure, or the clinical is a cerebral palsy or something of that sort,
Correct.
then the chances go double to 60.
60. Correct.
But
Okay.
there's still
So,
40% who don't have a seizure. So,
correct.
that also has to be
So
considered.
as I understand, first unprovoked seizure, after you control the seizure either on its own with your drug, you will do an EEG and MRI. If you don't find anything, just leave them alone and tell them how to treat the second conversion at home. And if they have a second seizure, then you would put them on the long-term anti-epileptic drugs.
That
All
also
right.
discussion ke baad.
Yeah. All right. We are not discussing epilepsy because that's a huge topic, especially the syndrome epilepsy. I presume there are more than 30 varieties of syndrome epilepsy which are known, and many more will keep on adding. They are genetic, they are primary, they are familial, they are all sorts of things, perinatal insults, etc. So we will leave the discussion there. All that we wanted is whether we would label the child as having epilepsy or no, and whether you will treat him with the long-term epilepsy. Maybe another episode of webinar, we will focus only on where we have left from today to discuss the epilepsy, because that will be very, very toxic to take. And I would request both of you, when we do the second part, to show videos. They are
Sure.
very interesting to show syndromic epilepsies and some 10 or 15 different types of epilepsy videos, and then some common drug. And you see a lot of newer drug like cosamide and things which I can't even pronounce at the age of 65. Leave aside, spell them, would leave it to you. But before we end, what are the four major types of seizure as per the new classification, and what is the bearing of that as far as the uh, labeling of epilepsy is concerned? Rajesh, you can take that, or Nitish, you can. Rajesh can take. Chal, Rajesh.
Yeah, so basically, the broad classification of seizures is focal, when it's coming with involving one network or one area, one network essentially, and then maybe spreading, or generalized, when it's coming from both sides almost simultaneously, so multiple or bilateral networks. Third is unknown.
Correct.
So because focal and generalized seizures will depend upon your first symptom.
Correct.
So let's give you an example. If you have a patient who says, I can't see very well, I'm seeing colored balls in front of my eyes, his eyes go to one side and he starts jerking on one side, he has had a focal seizure because he had the aura. It tells you it's starting from one area of the brain, most likely occipital lobe in this case.
Correct.
Because you have another patient who gets up in the morning, has brushing his teeth, and suddenly falls down without any idea, has a generalized tonic-clonic seizure, bites his tongue and passes urine. And that patient, you can use EEG also in both these things, and has a generalized discharge on the
Correct.
EEG, or a generalized seizure. There's no cut and dried kind of thing.
Correct.
On the other thing is, suppose you get up, the patient's mother is sleeping, and suddenly gets up because there's some noise, and then you see same kind of generalized tonic-clonic seizure, you cannot call it generalized because you are not at the beginning of the seizure. So you don't know whether it started first on the right and then went to the generalized. So you call it unknown.
Okay.
And finally, the last thing is unclassified. So it could
So
be a
where do myoclonic jerks come in this? They are known or they are
generalized.
generalized? Okay. And the fourth one you were saying?
Unclassified. Now that's very unusual. So you cannot classify into what exactly, which either focal, generalized, or unknown or something.
How does it help? I mean, it's okay to know,
Well,
but does treatment wise?
so classification of seizures is because there are different levels. For example, a general practitioner may want to just classify it as focal, generalized, unknown. Forget about unclassified. That's a very unusual thing. Second is, for example, unclassified would be, for example, I forget about unclassified. We hardly see that. Second is for a general practitioner, a pediatrician. You want to know difference of focal would be, say, visual seizures or whatever, pediatrician or a pediatric neurologist, or generalized would be myoclonus, absence, that kind of. So focal, motor. So there are different ways of classifying. So there are different levels. And then an epileptologist would know the syndromes and, those kind of things.
But many things are because treatment differs. Your initial treatment differs, and there are drugs which are contraindicating something.
Give example.
Correct.
So say like the focal seizures, I'll be very happy to use carbamazepine. But for generalized seizures like myoclonic or absence, if I use carbamazepine, it's going to make it
worsen. Correct. All right. Okay. I think with that we end today's discussion, because our discussion was on the seizures in children and not epilepsy. Epilepsy is a Pandora's box. So we are very happy that we could all finish all the questions in very much in time. We have almost discussed for 1 hour and 20 minutes. So any last minute message? First Nitish and then Rajesh.
Okay, sir. So basically, uh, parents' education, safety advice, counseling, and thoroughness of the history, who it takes, how it started, all those things. And for the seizures, based drug, based route, based dose.
Rajesh.
No, I think I emphasize that diagnosis is purely on history. That's one thing we do not take in detail. Number two is, when you're choosing a drug, be very careful. Because what drug you choose is not something like giving antibiotics for 7 days, where you might go wrong also, it doesn't really matter that much. But over here, for 2 years, you're choosing a drug. Say, for example, you give a drug which is, anyway, we can talk about this later, but valproate in somebody who's already overweight, you'll have a problem. So those kind of things. And third thing is counseling is something which you need to, because they are very the parents are very anxious about this. It's a horrible thing to see. Very anxious, is almost, so that's why this counseling has to take a lot of time.
Correct. Right. So I think with that we end. We really
Nitin,
thank Dr. Atanu Badra, Dr.
Nitin
Jalil
bhai,
Ahmed, Dr. Yagnesh, Krunal Shah, Baldev Bhai, Nandini, Shingaravellu, Bella Verma, Satish Bhai, Rajesh Kulkarni, and so many who have joined here, and many
Nit-
more who have joined the web stream platform primarily, which was meant for the viewers link. Yes,
Nit-
over to Dr. Ramesh.
Yeah, Nitin bhai. In fact, initially I got disconnected, so we invited Dr. Atanu Badra today as a chief guest. So I
Yes.
would like to, Dr. Atanu Badra to speak few words.
Yes, please.
Yeah.
Atanu Badra is not only the treasurer of IIP, but he's going to be the treasurer of the Pedicon as an organizing person, chief organizing secretary. Atanu, please go ahead.
No, sir. I don't want to dilute the hardcore academics. And no doubt, this is the long-term, this is the longest running academic program on the virtual platform. I just have an idea that many of our members, it should have been, most of the members should have listened to this discussion today. So for those who missed it, I would request Dr. Ramesh to think about a publication of a compendium of these question and answer sessions.
Thank you so
I
much,
think
sir.
that would be great for all of us. And
So,
of course, yes, for all of us, febrile seizures is something that we all face, and it's a bread and butter of many of us. So
I
I think
always
thanks,
say,
Dr. Nitin sir, President, and really it was brilliant. It was brilliant.
so we
And
say febrile
really,
convulsion is the bread and butter of pediatrician, and epilepsy is the bread and butter of neurologists. No,
thank
so
you,
very
sir.
good.
Thank you.
So for all those who have missed this, this same link will be live for another 24 hours, and then the entire video will be uploaded on the Gujarat Pediatricians WhatsApp group YouTube channel. And Dr. Ramesh Bajania will again put the link for the YouTube channel. You can subscribe to it, and you can press the bell button so that you get, whenever the new video comes, you get an update. And at leisure, you can see it over the next whatever few weeks, few days, few months. In fact, of this series, the first one was on the labs in hematology, which was the first 12 months back. That was last year. It has crossed more than 2,500 views already. So please take your own time at leisure and do listen to this two maestros, Dr. Brajesh and Dr. Nitish. And of course, for some time, we also had Dr. Lokesh.
Okay.
Unfortunately, he was in some family problems, so he could not continue to join. Anyway, we will have him next time when we discuss the epilepsy. Over to Dr. Ramesh to conclude the session.
So thank you so much today's esteemed faculty, Dr. Brajesh Bhai, Dr. Nitish sir, and as Nitish Bhai has requested, we'll be waiting for a next session and with huge collection from Dr. Brajesh Sudani of excellent videos. So that would be coming up in. And thank you, Dr. Lokesh sir, also for a brief period of time. We can understand your social commitment. Thank you all, respected seniors and dear friends, for being there. And as Nitin Bhai said, we'll post and share the recording link of today's program. So be there next month and wait for our next program. Till then, thank you so much. Nitin Bhai always makes every month. I mean, I feel sometimes he acts like a rheumatologist, sometimes he acts like a hematologist, and he go into the skin of the character and brings out the questions in a manner that a common pediatrician finds it very easy to understand. So thank you so much, Nitin Bhai, for always being there at Gujarat Pediatrician WhatsApp group.
Nitin sir is the Ronaldo of IIP.
Absolutely. That's a correct word.
My
pleasure,
absolute pleasure. No
thank
problem.
you so much, Zydus, for giving us this platform and giving us a platform for YouTube uploading also. Thank you so much.
Thank you.
Okay, everyone.
Thank you,
Good
sir.
night.
Thank you,
Bye-bye.
everyone.
Good night.
Thank you.
Good night.